Hello, I am doing the lecture on chapter 24, the neurologic system. This is a big system and it can be a little complicated, so please take notes and try to um, do the best that you can. Okay, so the nervous system. The nervous system is the central nervous system and the peripheral nervous system. The central nervous system includes the brain and the spinal cord. The peripheral nervous system includes all the nerve fibers that's outside of the brain and the spinal cord. And that includes the 12 pairs of cranial nerves and then 31 pairs of spinal nerves and all their branches. Okay, culture and genetics. Racial and ethnic disparity noted related relative to strokes. 4% of African Americans have had a stroke. 6% of Indians slash Alaska natives have had a stroke, and 2.5% of Hispanics have had a stroke. Geographic disparity noted relative to strokes, existence of stroke belt. And basically, that's 8 states with increased stroke mortality. Nationwide burden of strokes is higher for African Americans and Hispanic populations. Subjective data questions. Subjective data questions, headache. When you do your subjective data, you want to make sure that you assess a person about whether or not they've had headaches, if they've had severe headaches, when did it start, how often does it occur, where do you feel these headaches? Do headaches seem to be associated with anything that you're doing? Head injury. Have you ever had any head injuries? When you had that part of a head injury, exactly where was the head injured, and did you have loss of consciousness? If you had loss of consciousness when you had the head injury, approximately for how long was that? Okay. When you ask questions, you may want to ask about dizziness and vertigo. Do you ever feel lightheaded? Um, Swimming sensation, like you're feeling faint. When have you noticed this? How often does it occur? Does it occur with activity or a change in position? Do you ever feel a sensation called vertigo, a rotational spinning sensation? Do you feel as if the room is spinning, or do you feel you are spinning? Does it come on suddenly or gradually? You can go into seizures when you're assessing people. Ever had any convulsions? When did they start? How often do they occur? When the seizure starts, do you have a warning sign? As far as your motor activity, where in the body do the seizures begin? Do the seizures travel through your body, or do they occur on one side or both? You want to know, do you have any associated signs such as a color change in the face or lips or loss of consciousness? Or do they have incontinence, which means that they urinate on themselves or have a bowel movement when those seizures occur? And are there any precipitating factors? Does anything seem to bring on the seizures, like such as activity, or if you discontinue a particular medication, or if you're very tired, or if you feel like you're stressed out? I remember telling you guys about a student that I had that, and that we had to really watch. Okay, seizures. When you have a seizure has what they call a postictal phase. And the postictal phase is after they have a seizure. And do you sleep? Do you have any confusion, weakness, headache, or a muscle ache, or are you on any medication? How have the seizures affected your daily life and your occupation? Do they have tremors, any shakes or tremors in their hands or face? And when does these start? Do they seem to grow worse with anxiety, intention, or rest? Do they affect their daily activities? So, uh, as far as subjective data, is this generalized or local? Does weakness occur with a particular movement? Is it hard to get up out of a chair with distal or small muscle weakness? Is it hard to open a jar, write, use scissors, or walk without tripping? You want to know about any problems with incoordination. Do they have any problems with balance when walking? Any falling? And if they do fall, which way? Do your legs seem to give away, or is there any clumsy movement? Do they have any numbness or tingling? Do they feel like they're having pins and needles? When does this start? Where do you feel it? Does it occur with activity? Difficulty swallowing. Is it hard for them to swallow? And do they have to have any swallowing, like solids or liquids? A lot of times in the hospital, they'll have people on certain types of liquid. They'll have where they have to put a thickener in their water or in their drinks so that they won't aspirate and you know it have to be a little bit more thicker. Have you experienced excessive saliva or drooling? Do they have any difficulty speaking? Do you have difficulty forming words or saying what you intend to say? When did you first notice this and how long did it last? So you want to know about all the significant history. You want to know if they've had a CVA, which is a cerebral vascular accident or stroke. You want to know if they've ever had a spinal cord injury, or have they ever had meningitis or encephalitis, where encephalitis is where the brain has swelled. Or did it start with a congenital defect? Or have they ever had a history of alcoholism where this may occur? You want to know if they've been exposed to anything in the environment or in as far as their occupation, or are you exposed to insecticides, lead, any type of organic solvents? Are they presently taking any particular medications now? If they drink, of course, you want to know about how much alcohol do they drink. And if so, you want to know how often and if it's each week or each day. And how about mood altering drugs such as any particular thing like a barbiturate or or a tranquilizer or something of that nature. Those are the type of things that you want to be aware of, and you want to know whether or not this individual have had anything that they've taken that was different from beforehand. When you have an aging adult, of course, you want to talk about dizziness. A lot of older people tend to have postural hypotension, where their blood pressure um, rises up, and then when they sit up, it drops down real quick, and they have to sit there and dangle for a minute. So in order for them to get their homeostasis, because a lot of times if an old person just hops up and start walking, they'll pass out sometimes because of that. So you want to know about the dizziness. For men, they want to ask about do they ever get up at night and feel faint while standing to urinate? How does this dizziness affect your daily activities? Are you able to drive safely and maneuver within your house safely? What safety modifications have you applied in your home if you tend to have problems with that? Okay, with aging, Have you noticed a decrease in memory or a change in their mental function? Have you felt any confusion? Does it come on suddenly or gradually? Have you noticed any tremors in your hands or your feet, face? Is it worse with anxiety, activity, or rest? Does it seem to be relieved with alcohol? All of these things are pertinent so that you can get some type of gauge. You want to know about blindness, vision changes. Uh, do these things occur along with the weakness? Do you have any loss of consciousness? All of these things are pertinent. So, when you are performing a screening for a neurologic examination on a well persons with no significant findings from the history, you want to perform a complete neurologic examination on a person. So, any type of neurological concerns would be headache, weakness, loss of coordination, or who have shown signs of some type of neurologic dysfunction in some sort. You will perform neurologic recheck examinations on persons who have demonstrated neurologic deficits who require periodic assessments, i.e., hospitalized persons or those in extended care. Okay, so integrate steps of the neurological examination with examination of particular parts of the body. Everybody knows about testing the various cranial nerves. Uh, and you want to test the superficial abdominal reflexes while you're assessing the abdomen. You're going to record all neurological data together as a functional unit. So you use the following sequence when you complete a neurological examination. You start off first with their mental status. After you complete their mental status, you go and you do your cranial nerves. Okay? Then you're going to assess their motor, like how we had them doing the Bromberg and how uh, they were doing like the strength test and that type of thing. Sensory, can they smell? Can they taste? Can they feel things in their hands? And then lastly, you would do the reflexes. So that is like the correct order. We've talked about it, and we'll see how you guys did on that. Okay, so the type of thing that you need, of course, you're going to need that pen light, that tongue blade, cotton swab, a cotton ball. A cotton swab is like a toothpick. I mean, a Q-tip, I'm sorry, or a cotton tip applicator, a cotton ball. You're going to need a tuning fork and then a percussion hammer. And we know that we tend to sometimes we have to um, do things a little different because of the environment that we're in. So you're going to assess the cranial nerve, number one. Everybody knows how to assess the cranial nerve. This is the olfactory nerve. The olfactory uh, is not always routinely checked, but if there's an opportunity to check it, you can do it. Um, and you can, if they don't smell, it could be due to head trauma, abnormal mental status, and they could have some type of tumor or intracranial lesion suspected. So you know that how you do this is to make sure the person closes their eyes and you occlude one nostril, and then you present a familiar substance like coffee, orange, vanilla, soap, or peppermint. And then after you do that, normally the person can identify an odor on each side of the nose. Normally, it's decreased with aging, and any asymmetry and sense of smell is really important. So you want to make sure that both of the nostrils on their own is able to smell. Then You assess cranial nerves too. You always assess the optic nerve. And what you do is you do the testing for visual acuity, which would be like the Snellen test. And then um, you would assess for the visual fields by doing confrontation, which the confrontation is for the peripheral areas. Also, you would look if you had an ophthalmoscope and you would look at the ocular fundus to determine the color, the size, and the shape of the optic disc. And remember, we talked about that and we talked about where the macula is located in conjunction to the optic disc and everything like that. So then, as you can tell, you would do three, four, and six. You wouldn't hit five yet because you would do the oculomotor, the trochlear, and the abducens. And basically these are motor nerves, and you want to know if a person has nystagmus by going in and out. You want to check extraocular movements, positions of the gaze, whether or not their pupils are direct and consensual and they accommodate. And this is where you would get the PE uh, ERL from, the PERLA, A. PERRLA. I'm sorry. Okay. And then you would do the palpebral fissures, usually equal in width. So you assess those things, and that would be three, four, and six. When you're looking for particularly like nystagmus, carefully noting the presence of nystagmus is one or both eyes. Uh, and what it is it's like a pendulum. It like it moves, it oscillates uh, equally left to right, or a jerk, a quick phase in one direction, then a slow phase in the other. And you want to check whether or not it's the degree of movement, whether it's fine, medium, or coarse. You want to know whether or not it's constant or it fades after a few beats. And then you want to note what the plane of the movement is, whether or not it's vertical, rotary, and or whether or not there's a combination. Okay, so then you'll go to cranial nerve 5, which is the trigeminal nerve. And so you're looking at stuff like their jaws and mastication, their ability to, it has a motor and a sensory function as well. And so you're going to assess the ophthalmic area, the maxillary area, and the mandibular. So for the motor, you're going to palpate the temporal area, and you're going to have them clench their teeth and ask them if they're feeling any discomfort. This is where you get into like the TMJ. Okay, and then you're going to do the muscles, and you should feel equally strong on both sides. You're going to have them try to separate the jaws by pushing down on the chin. And what you're trying to do is you're trying to push down on the chin and see if you can open it, and usually you can't, or you shouldn't be able to because they have that strength. Sensory, with their eye closed, you want to use that cotton ball that you had, and then you want to whisk on their forehead, on their cheeks, and on their chin, and ask them if they can feel it. The corneal reflex, which is really, you have to be kind of careful. Uh, but what you're doing basically, uh, you don't necessarily want to check that unless the person has some type of abnormal facial sensation or any abnormalities of facial movement. If they're not having any of those, you don't necessarily have to check for the corneal reflex. But if you do see that you saw that they've had some type of abnormal movement or something of that sort, what you would do is, if they're wearing contacts, they would have to remove their lenses. And with the person looking forward, you bring a wisp of cotton in from the sides and lightly touch the cornea, not the conjunctiva, but just lightly touch the cornea. And you come from the side because you don't want them to uh, blink, defensively, like. And usually, when you do that, usually the person will blink bilaterally. Corneal reflex may be decreased or absent in those who have worn a lot of contacts lens because they almost like train themselves, to not have as much problems. You know how like some people when they're putting in uh contacts a lot, they get really, really good at that and it doesn't affect them in that manner. This procedure tests, like I say, sensory afferent in cranial nerve 5 and motor efferent in cranial 7, which is the muscle that closes the eyes. So cranial 7, which is the facial nerve, you want to note the mobility. You want to ask them to lift their eyebrows, smile, puff out their cheeks, show their teeth. That is what you're looking at. As far as sensory, um, test the sense of taste by applying a cotton applicator covered with something and or lemon juice, sugar, salt, or something that asks the person to identify the taste. A lot of times, especially if you're in an environment where a medical environment, you may not be able to taste routinely check that taste. But if you have the ability to do it, you can. Cranial nerve 8, which is the acoustic nerve. You're going to basically test your hearing acuity by ability to hear normal conversation and by doing the whisper voice test. Everybody's clear on how to do the whisper test by having them squeeze on the tragus on one side, and then you're like whispering something, you're about an arm length away on the other side, and they'll repeat it like maybe three little words or three alphabet or three numbers, something of that nature. Then you have cranial nerves 9 and 10, which is the glossopharyngeus and the vagus nerve. Motor function, you want the person to show whether or not they can say ah, or they can yawn. You want to look at the uvula as they're doing that when you're depressing down with a tongue blade and the soft palate, and it should rise and it should be in mid lung line, and the tonsillar pillar should move medially. You're going to touch the posterior pharyngeal wall with the tongue braid lightly and note the gag reflex, and the voice should sound smooth and not strained. Sensory function cranial nerve 9 does mediate taste on posterior one-third of the tongue, but technically it's too difficult to basically test. Cranial nerve 11 is the spinal accessory nerve, and that's when you have them um, basically uh, push up against your hand with their chin on both sides. It should, while they're rotating their head, it should be the same because you're testing the sternomastoid and the trapezius muscles going down the neck as the person to shrug their shoulders with you holding the palms of your hand up on their shoulder and pull and applying a little resistance. These movements should feel equally strong on both sides. And then lastly, the hypoglossal nerve. You inspect the tongue, no wasting or tremor should be present. You note forward thrust in the midline as a person protrudes the tongue. And then you ask the person, light, tight, dynamite. And note that the lingual speech sounds of letters L, T, and D is clear, and make sure that it's really distinct in your ear and you're able to hear it. So you're going to inspect and you're going to palpate motor systems, muscles. Number one, you're going to inspect all muscle groups for size. You're going to compare the right side with the left. You're going to do the muscle groups that should be within the normal size limits for the age, and it should be symmetric. So you're looking at them. If it's a difference of like maybe 1 centimeter or less as far as the muscles that you know in the extremities, that's not very significant. But note that if it's a difficult to assess if a person is obese, to assess that muscles. Inspect the extremities of the neck and the trunk. Note normal tension and relaxed muscles. Uh, Note if there's any type of involuntary movement at all within their muscles. Uh, and then you're going to do what they call the cerebellar function test, balance test, the gait. Remember what y'all remember the tandem walk and that type of thing. You're going to notice, do the Romberg test. You're going to have them walk on their toes. You're going to have them walk on their heels a few steps, and you want to make sure that the cerebellum is functioning and they have balance. Also, I did mention the Romberg, where you ask the person to stand up with the feet together and the arms at their sides. And when they're in a stable position, ask the person to close their eyes and to hold that position for about 20 seconds. Normally, the person can maintain posture and balance even with visual orienting information blocked. As a person to perform shallow knee bend or hop in place, first one leg, then another, if they're able to do that. And some individuals, they may not be able to do that because of just aging or obesity. You want to do the rapid alternating movements, patting their knees with both hands, lift up, turn hands over, and pat knees with the back of their hands, what we call the patty cake, alternating as person to touch the thumb to each of their fingers on the same hand, then reverse the direction, have them do it first one direction, then the other with the same hand. um, Rapid alternating movements, finger to finger test with their eyes open. Ask the person to use their index finger to touch your finger, then their own nose, and move your finger to continue the test. Uh, it should be like kind of smooth and accurate. Finger to nose, the eyes closed, the person stretched out arms, and they touch the tip of their uh, nose with each index finger, and they're alternating the hands and increasing speed. So normally this is done with accurate and smooth movement. Heel to shin test, ask the person in the supine position to place heel on the opposite knee and run it down the shin to the ankle. Normally the person moves the heel in straight line down the shin. They usually have no problem. Assess the sensory system. Ask the person to identify various sensory stimuli. What you do is um, light, touch, and vibration. Um, Complete the testing of sensory warranted in those with neurological system, like if they have a localized pain, numbness, or tingling, or something like that, because you're looking if their peripheral nerve fibers and stuff are intact. You're going to compare the sensations on the symmetric body parts of the person. When you find a definite decrease in sensation, map it by systematic testing in that area. Okay, so if they have a problem where they don't have no sensation, you want to do it again. You want to do it in another way because you want to see, make sure that that area is deficient. Okay, persons, the eyes should be closed during these particular tests and take time to explain to the person what you're going to do. Like when you're, tell me if this soft, tell me if this hard, tell me if this is blunt, tell me if this is sharp, like that type, or dull, that type of testing. Okay, so when you guys are doing the reflexes and you're or the deep tendon reflexes, know that when you do the reflexes, there are four, well, really kind of five different responses. They can have a zero response, they can have a diminished, they can have a two, which is average, and then they average, they can have a really brisker than average, which may indicate some type of disease, or they can have a very brisk, which is a four, which is in which is hyperactive with clonus, and that's indicative of a disease. So uh, so in order for you to be able to do it, you have to make sure that that person, you guys, is getting the test, you're hitting at the correct spot, and the person is relaxed. And because even though they have this scale, and even though you can kind of know about the scale, a lot of times the scale may not always be necessarily correct. Okay, so okay, so just the description of testing the reflexes. You got biceps reflex, and that's C5 to C6. That's when you support the person's forearm on yours, right? And you place your thumb on the biceps tendon and strike a blow on your thumb. And what the normal response is a contraction of the biceps muscle and a flexion of the forearm. For the triceps, tell the person to let the arm just go dead, like, and as you strike the triceps tendon directly just above the elbow, the normal response is extension of the forearm. Okay, brachioradialis reflex C5 to C6. You hold the person's thumbs to suspend forearms in relaxation, and you strike the forearm directly, about 2 to 3 centimeters above the radial styloid process. A normal response is flexion and supination of the forearm. The quadriceps reflex, which is the knee jerk, you let the lower legs dangle and you stretch your tendons, strike the tendon directly just below the patella, and the normal response is they'll, extend the lower leg. And then the Achilles reflex, which is the L5 to S2 or ankle jerk, is when you position the person with the knees flexed again and you hold the foot in the dorsiflexion and you strike the Achilles tendon directly. Normal response is usually the foot plantar flexes against your hand. Okay, so the clonus test when reflexes are hyperactive. What you do is you support the lower leg in one hand, and with the other hand, you move the foot up and down to relax the muscle. Then you strike the muscle by briskly dorsiflexing the foot, hold the stretch. Normal response, you feel no further movement. When the clonus is present, you will note rapid rhythmic contractions of the calf. Um, so use the same examinations that you use as with younger adults with older aging people. The cranial nerves mediating taste and smell are not usually tested because of the fact that, you know, when you're doing taste and smell, there's quite a little bit of a decline sometimes when the person gets older. There will be sometimes a decrease in the muscle bulk, most apparent in hand, dorsal hand muscles, and they often look a little bit like, wasted even with no apparent arthropathy. So the grip strength remains relatively good. Senile tremors occasionally occur, but these are benign tremors include an intention tremors of hands or head nodding and tongue protrusion. Okay, dyskinesias is a repetitive stereotyped movement in the jaw, lips, or tongue, and it may accompany senile tremors. No associated rigidity should be present. Gait may be slower and more deliberate. Rapid alternating movements as far as maybe difficult for them to perform. And after 65 years of age, loss of sensation of vibration at the ankle, malleolus, may be common, and loss of the ankle jerk and tactile sensation may be impaired. And you may need a stronger stimuli for light touching, especially to elicit any type of pain. Deep tendon reflexes are less brisk. When you have a person that's older, their plantar reflex may be absent or difficult to interpret, and their superficial abdominal reflexes may be absent. And this occurred uh, because of the fact that a person might be obese and not have as much muscle, or even if you're doing a person that has a pregnancy, it may be hard to elicit as well. Some hospitalized persons may have head trauma or a neurological deficit, and it's to systematic disease process. And when you do that, you must be monitored closely for any improvement or deterioration in their neurological status. So if a person has some type of cerebral injury, a trauma, or something, you'll see them in the hospital putting them on neuro checks and stuff. You'll see that they'll look at their level of consciousness, their motor function, their pupillary response, and they'll assess their vital signs in that order. So that is, like a common thing that if they have somebody that has some type of injury. So the level of conscious is the single most important factor in uh, this examination. Motor function, you check voluntary responses by giving simple commands, uh, and that helps validate their level of consciousness. The pupillary response, you need to note the size and symmetry of both pupils. The vital signs, you need to monitor the vital signs to establish a baseline. And then also, uh, a lot of times they will use what they call the Glasgow coma scale when they are assessing a person to see, as far as how they're doing. Oh, and I do want to speak on the Glasgow coma scale a little bit. The Glasgow coma scale is used, basically what it does is it describes the level of consciousness for a person, and they say it's a pretty accurate tool to use. So it gives things like a numeric value, and the scale is like divided into like three areas. They have an eye opening, a verbal response, and a motor response. And each area is rated separately. The eye opening response is 1 through 4, 4 being like spontaneous. And the motor and response is 1 through 6, which 6 is like, for instance, you um, obey a verbal command. And then the verbal response is when you answer a correctly verbal response, and that's 1 through 5. So that would be 5. And each number one, if they do a 1, that means there's like no response. And so a fully alert normal person has a score of 15, where like if you got a score of 7 or less, that reflects kind of like a coma. Uh, and that lets a person know whether or not somebody is deteriorating or not. So that may be you'll see those. Cool. So when you do a sample charting, it has on here that subjective, no unusual, frequent, or severe headaches, no head injury, dizziness, or vertigo, seizures, or tremors, no weakness, numbness, or tingling, difficulty swallowing or speaking, has no past history of stroke, spinal cord injury, meningitis, or alcoholism. So those are the type of things based on the questions that you would ask a person, right? So, objective charting, you'll have mental status, appearance, behavior, and speech appropriate, alert and oriented to person, place, and time, recent and remote memory intact. Remember, I always told y'all about the recent memory for older people being less than the remote. And then they have uh, a lot of a brief comment on all the cranial nerves. Like for instance, cranial nerve 2, vision 2020 OS, 2020 OD. Okay, so they saying the left and the right eye. Peripheral fields intact by confrontation, fundi normal. So it's just like a normal, you know, like they talking about no ptosis for 3, 4, and 6. Ptosis is that drooping, no nystagmus, pupils equal, round, reactive to light, and accommodation, which is PERRLA. Uh, they just speaking on all the things that we've had you do. And then motor, there's no atrophy, weakness, or tremors. So these are the type of you know things that you would put when you would chart. Stereognosis, able to identify a key. You know what I'm saying? No Babinski sign. Remember we talked about Babinski with the toes flaring out upward instead of downward, uh, which that shows that there may be some type of damage. Okay. There are also like 4 different types of abnormalities in muscle tone. The first one would be flaccidity, flaccidity. Um, that's like decreased muscle tone when your muscle feels limp and soft and flabby, and muscle is weak and it's easily uh, it's like a rag doll. That's kind of like a flaccidity. Spasticity mean that it's hypertonia, which means there may be suddenly give way, like a pocket knife sprung open. Like, for instance, there may be a jerk or spasticity. Rigidity means a constant state of resistance, resist passive movement in any uh, 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 direction or dystonia. And then cogwheel rigidity is a type of rigidity in which the increased tone is released by degrees during passive range of motion. So it feels like small, regular little jerk. But um, remember, with rigidity, it resists passive. Okay. With the cogwheel rigidity, there is degrees of jerks doing passive. So you gotta remember those type of terminologies. So there are also other various abnormalities, like for instance paralysis. This a decreased or loss of motor function. Paralysis can be caused by trauma, spinal cord injury, stroke, Bell palsy, neuropathy, muscular dystrophy, multiple sclerosis, myasthenia gravis, or those type of things. Then you have hemiplegia, which is a paralysis on right or left side of the body. Paraplegia, which is when a person have paralysis of both of their lower extremity, and then quadriplegic, where all four extremities are weak and you know and paresis is like a weakness more so than paralysis. Then there's what they call fasciculations. Fasciculations is rapid, continuous twitching. Rapid um, twitching. And that's usually caused by a lower motor neuron, problem. So think fasciculations, a tic. A tic is like an involuntary, compulsive, repetitive twitching of a muscle group. It might be a wink, it might be a grimace, it might be a head movement. That's what makes um, Tourette syndrome and people with tardive dyskinesias, or they may have a habit tic. You have myoclonus, which is a rapid sudden jerk or a short series of jerks. Okay. Oh, let me see. Uh, a seizure disorder is a time limited event caused by excessive, like hypersynchronous discharge of neurons in the brain. And it may be from a clear provocation like a cerebral trauma or a structural lesion or infection. It may have been generalized seizures, which involves the entire brain. They have distinct phases like loss of consciousness, then the muscle rigidity, then the contractions and grimacing, and then they have a postictal phase, which is the sleeping, disorientation, or such. So that's like a seizure disorder. You have tremors, which are involuntary contractions of different opposing muscle groups. You have a rest tremor. It occurs when the muscles are quiet and they're supported by gravity. and it completely disappears with voluntary movement. So that's, and then you have an intention tremor. Uh, it just kind of depends. It's worse with voluntary movement, as in when you doing the when y'all do the hand to the finger to finger or something like that on a person, you'll see the tremor. That's an example of a way the person has an intention tremor. If it's shaking, doing that particular time. Then there's chorea, and that's a sudden, rapid, jerky, purposeless movement involving limbs, trunk, or face. And then the athetosis is a slow, twisting, continuous movement, which resembles kind of like a snake or a worm. So there are a lot of different types of uh, abnormal gaits. For instance, they have spastic uh, hemiparesis, which the arm is immobile against the body and stuff, and the person kind of walks like, but the arm is, you know, and the leg is stiff, and they drag the toe kind of like in a semicircle. That's kind of like a spastic hemiparesis. Cerebellar ataxia is a staggering and um, a wide base gait, and they have difficulty with turns. Um, that's usually, they say a lot of times that happens when a person is on alcohol. That's cerebellar ataxia or some type of barbiturate. And then they say also people with multiple sclerosis has it as well. Parkinsonian festinating is a posture which is stooped, the trunk is pitched forward, and the steps are short and shuffling. Scissors is kind of like when the knees are in contact and the person uses short steps, and the walking requires a lot of effort. So the knees are in contact when you see somebody doing the scissors. Steppage or foot drop, they look kind of like they're walking up some stairs, but there's no stairs there. Waddling is when a person has real weak hip or muscles. Uh, and so, like, it's kind of like when they take one step, the other hip drops a little bit, you know. And then the short leg is when the leg, there's a discrepancy. And that's usually, something congenital as far as a person. Common patterns of motor system or dysfunction. You got cerebral palsy, where there's it's due to damage to the cerebral cortex. Uh, a lot of times you'll see that. Muscular dystrophy is wasting of the skeletal musculature, and a lot of times that is chronic. Hemiplegia is damage to, I think it's the spinal or the cortical spinal tract. And it's usually secondary to like when a person has a stroke or something. So and y'all know that's one side. Parkinsonism is has to do with the loss of dopamine in the neurons and basal ganglia, and they have that rigidity, that cogwheel type of rigidity and loss of balance. Um, cerebellar is they usually have a lot of ataxia and they're lurching forward of the affected side while walking with rapid alternating movements. We know what paraplegia is when they have damage to the spine or spinal cord injury. And then the multiple sclerosis is kind of like a immune mediated disease. So that's uh, they have Babinski with multiple sclerosis, extreme fatigue, weakness, spasticity, and it usually affects younger folks because they said the average age is like about 30, 32, 30, like that. Okay, so this is basically this I know probably seemed like a lot, to take in, but I do want you guys to be aware of it, and you may have to refer back to your book about reflexes and different types of. One thing is the different types of abnormal postures uh, that like the corticate rigidity, the the cerebrate rigidity. I mean, there's different types, and I'll ask you guys about that. But if I ask you about that, it would be on the test. And just basically, I'm wanting you guys to just have an idea of some of the things. I don't necessarily expect for you to just it is because the neurologics are very, very, very can be very, very difficult, you know, to learn. I would like for you guys to be familiar with the four lobes, the frontal, parietal, occipital, and temporal. Like the frontal lobe is for personality and intellect and emotions and behavior. Parietal is mainly for sensation. Occipital is for vision, and then the temporal is the hearing, taste, and smell. That type of thing. I would like for y'all to be aware of those. Other than that, that's it. And good luck, you guys. And any questions, just feel free to ask me tomorrow on Thursday. Thank you. Bye.